recording, but we'll go. So good morning, everybody. Afternoon, today, January 9th, 2024. These are SEVA VentRounds. And today we're going to be talking about why breath sequence matters when you talk about modes of mechanical ventilation with this interesting case we had. There's no endorsement of any module, of any mode, manufacturer or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. It's a recorded session. If you want to say something, please put it on the chat. I can see it constantly, as well as Rob. And obviously, if you want to speak up, you can also mute yourself and then speak up, but then just mute your microphone again. There's CMEs for the CCF staff and CRCEs for anybody anywhere in the country that wants to get CRCs. Just put your name on the chat and you'll get your CRCE. And at the end, there's an evaluation that you have to complete within an hour of doing this event. So the basic SEVA knowledge that I would like to highlight today is the following. It's talking about trigger synchrony and what do we mean by, how do we classify it? And here in the yellow box, you can see a P band, so in orange, the pressure that the ventilator delivers. Then a fictional depiction of PMOS. So this is how, in the red line, how PMOS would look in this patient in particular. In green, you have the flow waveform, and in blue, you have the volume waveform. And in the yellow box, you can see a normal trigger. There will always be a little bit of delay between the PMOS and the activation of the P vent, just because it has to travel the circuit and whatnot. But there is and there's still not a very good definition of how late is late. But there, if you notice, for a normal trigger, in this example that we put here, there is activation of PMOS, the pressure drops, and then it activates the pressurization of the waveform. And this was a flow trigger, as you see here. In comparison, a late trigger in which there is activity PMOS, and you can see that it takes a fair amount of time for the flow has crossed over above the baseline, and it takes a fair amount for the system to pressurize. So this would be consistent, with a late trigger. So it occurs later than what it should have happened. And then on the other spectrum is what we call early trigger, in which you have the machine, so the ventilator, the machine breath, the liver breath starts, so the machine triggered this breath, and then later there's activity of the patient, so PMOS, and you can see that with the deformations that occur on this waveform, how the flow increases at the end of this breath, and how the volume actually increases because of the presence of PMOS. So that for early trigger, so the ventilator triggers and then the patient. Here you have patient activity from the get-go, and then the ventilator triggers, and here there's a delay after the patient activity to it happening. So this early and late will help you. Now, a common question is, well, Eduardo, in the literature, this has been called reverse trigger, but there's a particular pattern that occurs with reverse trigger and with a particular physiopathology, and there's other etiologies that can give you an early trigger. And so for that particular reason, we didn't call it reverse trigger, we call it early trigger, because one of the causes is reverse trigger. So just for you to be aware. Rob, comments?
That's a good summary. Nothing to add.
And so let's move on to the case. You got a glimpse as I was moving through this slide. So I want you to take a look for a couple of seconds, and we are disclosing the full slide here of a patient, and just so that you have an idea. This patient was on pressure control, and then we activated the auto mode. And this is the transition from activity from us activating the auto mode on this patient from being on pressure control to being on auto mode. And so this had a good transition. So we decided to put that here for you to be able to see it. So as you know, when we do these VentRounds, there's a moment in which we need you to tell us what's the tag. So in the chat, if you want to type in what is the tag, this will help us move along, and I'll just put it here. So test yourself, put in what you think is actually the tag for this mode. And remember, there's several tools available. We have the Vent Mode app. We have published on this extensively on what are the tags for these modes.
Eduardo, can I say
Yes.
something? I think that the
Yeah,
mode is auto mode from the beginning, but the first breath doesn't trigger the second breath, so it doesn't switch from pressure control to pressure support as it does on the third one.
Yeah, we're gonna get to that, Ariel. So let's start with the tag first. So I'm seeing a couple of our teams are putting in, and so you're correct on some of the tags. There's so without a doubt this is PC, and we know that because the flow is not being controlled, and you can see the volume how it's varying from one to the other. And then many of you have put in that this is a IMB type of breath sequence. And Rob reminds you all that there's different types of IMB, and one of them is the one that this patient in particular is on auto mode is type 2, in which essentially you have mandatory breaths and spontaneous breaths, and the spontaneous breaths suppress the mandatory breaths. And we're going to talk a little bit more on this breath sequence in particular, this mode, and Rob and Ariel have just published, or it just got published, the article on how this mode in particular works, and we'll ask you to speak a little bit about this. But the targeting scheme for this one is SS, and that's important to know. There's different types of auto mode. This is one of them that has that we're pressure control and pressure support, and for those we have to enter the value for the pressure control above PEEP, so we put 10 here, and for pressure support 10. And so the spontaneous and the mandatory breaths are like this. Comments, Rob, on this?
No, that's good. Just that it's S because pressure control is S, and the second S, the spontaneous breath, is S because pressure support is set point targeting, both set point targeting.
Excellent. So we'll come back to the targeting scheme in a second. Let's finish reading this. Not the targeting, the whole tag in a second. But what do you think is the load? Elastic, resistive, or PMOS? This is the moment where you test yourself just by looking at the waveforms. What do you think is the main load? And remember, you can see both the inspiratory phase as well as the expiratory phase. And sometimes you have, as you all are seeing, is the presence of PMOS, and so during inspiration and during expiration. So without a doubt, you have during the first breath the presence of PMOS, and you know that because you see a machine triggered breath, but then the flow, instead of decaying exponentially as it should be coming down little by little like that. It has this bump up. However, on the second breath, there seems to be probably, there may be some PMOS here, but it's small. But then you see the exhalation and you don't see any evidence of PMOS there. So by looking at the expiratory phase of the second breath, that can help you in a bit define what type of, yeah, there you go. So Michael, that's correct. So it looks probably more on the elastic behavior. And remember, elastic is the main driver on this group of patients. And in our patients, that's the main load for the majority of them. So I would say that this is probably elastic load. Rob?
Yeah, that's a short time constant. I would probably say the same thing.
Okay. So remember, sometimes you will not be able to see in some, but you will be able to see later on in other breaths, so or in other areas, and that can help you figure out what it is. So in terms of PV discordance, what do you think is going on in terms of trigger? Is it normal, early, late, false, or failed? Yeah. So well. So we have three breaths, and so thank you for pointing that out, Michael. There's three breaths. Well, there's actually, well, yeah, three breaths. I'm gonna call them three. So the first one is early trigger, as many have pointed out. That's correct. So that would be an early trigger. So you have the classic feature of a mandatory breath, and we know it's mandatory, and remember, each ventilator is different, but this one will show us if it's triggered by, if the ventilator is interpreting that this is the patient, it will change color, and you will see here, for example, it's a flow trigger, and you can see the white line on the third breath on the end of that. You're going to see that's consistent with somebody that has pressure, a flow trigger. So that's what you would see. So you don't see that. So this means that this is a mandatory breath, and there's followed by evidence of patient activity. This is a mandatory breath, but I don't see any evidence of patient activity, even though the flow looks a little bit abnormal there, but I don't see much here. So I would say that this is just a passive breath. And then the last one is again mandatory, but now I see evidence of patient activity. So this is an early trigger on the first breath and the third breath. So that's absolutely correct for those that recognize that. And then you remember that once that you see an early trigger, that will generate a series of other abnormalities. So you will recognize that this may look like work shifting, this area over here, as well as this one over here. But we don't call it anymore, so we don't grade those because the one that we have to solve is the early trigger. So the early trigger will cause problems, and actually on this one it causes an early cycle, and that's why you get this double breath or multiple triggers. So we stop looking at inspiration and cycle, and actually during expiration there's probably a little bit of work, I would say, but I would call it mostly normal unless somebody has something against that. But so remember, you have when the first discordance that you see is the one that it may cause others. So the one that you have to solve is the first one that you see, because that will help you then. If there's others that appear after you fix the first one, then you deal with the second one, and then the third one, and whatever you need to deal with. Rob, comments?
This is a perfect example of how, as you say, one cause can lead to several effects. So the initial cause is the early trigger. It can show up then as causing work shifting, early cycle, and double triggering. So if you were to start off from and try to name all those synchrony problems, you'd get lost, right? So the way to get organized is to figure out what's the initial cause and what are the subsequent effects.
That's correct. So, and this also serves as a reminder that that when you have a double trigger or breath stacking, as some people call it, or multiple trigger, as we call it. When you have a multiple trigger, there's three main causes, and the three main causes are early trigger, which you're seeing right here, early cycle, and false trigger. Those are the three common causes of this anomaly that you see here. So just for your now, Ariel, you mentioned so you just wrote a paper, a very nice paper on this, and so we see evidence of activity here that obviously didn't trigger a spontaneous breath. Then there's a mandatory breath, and then there's this mandatory breath, and then it triggers a spontaneous breath, and it changes this to this pressure support CPAP targeting scheme. Can you talk a little bit about how auto mode works?
You're muted, Ari.
Auto mode is composed of two modes. Pressure control, in this case, pressure control and pressure support. We see volume control and volume support. And the other one is PRVC and volume support. Depending who triggers the breath, it triggers the change. If the breath is triggered by the machine, it's going to be the mandatory mode, in this case, pressure control. The switch to the spontaneous breath is done based on when the patient triggers, it switches to the spontaneous mode, in this case, CPAP. What the machine basically does is when the patient triggers a breath, it removes the set inspiratory time in favor of a variable one of a pressure support breath. In this case, in the first breath, the effort comes after the machine trigger breath, and it's not long enough to trigger a second one. In the case of the third one, the effort is long enough, and it triggers a pressure-supported breath. Also, what is, if you can observe the pressure-supported breath, the number third, the tidal volume is much larger than the first one. That's my observation, Eduardo.
Yeah, and so this is actually, so this patient, so to put it into perspective, so I switched him from pressure controlled in the mode that the patient was to auto mode, and so had a couple of these breaths, and then started breathing on its own. So once that the breath that the pressure support breath kicked in, and this was the next series of breath, and you can see that now the patient is breathing spontaneously. So all the breaths are triggered by the patient and cycled by the patient. And if the patient would fall below, so reaches an apnea time, and I want you to talk about how that works, because that's not entirely clear on the manual. And if you could talk a little bit about what if I put a patient on auto mode, it's relatively easy to understand that if there's patient effort, it will go into only spontaneous breaths, as in this case, and that was the solution for this patient. But if the patient would go apneic or drop the respiratory rate, how does it go back to mandatory breaths? Can you talk about that?
Are you asking me, Eduardo, or Rob?
Yes. Well, you wrote the paper with Rob, so I'm giving you.
We need to start by defining the apnea time. The apnea time is the time the machine waits for a spontaneous effort to appear before reintroducing a mandatory breath. In auto mode is different than any other mode because the apnea time is called maximum apnea time, and it has a range from 7 to 12 seconds. Normally in pressure support, we set it at 20 seconds, so if no inspiratory effort happens in 20 seconds, a mandatory breath going to be reintroduced with what we call the backup apnea alarm. Auto mode is a mode that we can say that introduce the backup apnea alarm into the maximum apnea time. So if no spontaneous breath happens in less than the maximum apnea time, a mandatory breath going to be reintroduced. But the specific thing of auto mode that wasn't mentioned even in the manual is that maximum apnea time is awarded after the patient produces 10 spontaneous breaths, and they are counted by the machine. In theory, if you become apneic after one spontaneous breath, the apnea time is going to be slightly larger than the cycle time. And every single breath gives the patient a little bit longer apnea time until it reaches the maximum apnea time. So what Rob well mentioned on the paper, this is an atypical way of automatically adjusting the apnea time. And I don't know if I should say like a intelligent way, but it's way shorter than any apnea time we know in pressure support. It's kind of, I would say, unusual.
Yeah. So thank you very much. And this just to highlight one, the paper, but number two, the fact that our knowledge base regarding how these algorithms work is scant, and so we have to continue to work into seeing how these modes work so that we can apply them better and know what to expect for our patients. So wonderful work from all of you. But overall, if you would assess this patient ventilator interaction, you can now see that the trigger is triggered by each one of the breaths from the patient, cycled by the patient, and the interaction is pretty decent for the patient that we're having. So in this case, the breath sequence of IMB type 2 helped the team just get out of the cycle of having this early trigger occur on these patients. And this happens relatively often to us when we are weaning patients from the sedatives and they start having reverse trigger or early trigger. And the response of the team sometimes is to resedate the patient. And again, as we talk about goal-directed ventilator management, your goal will define what you do. And in this case, if we're trying to aim for comfort and waking up the patient, then this type of breath sequence may help you get out of that pickle. Here you have the CMEs for the CCF caregivers. You scan that. And if you have CRCs for our RTs on the call, you can scan this one. Again, please send us your waveforms. We will put them shamelessly and give you credit for it and discuss them on the here every single time that we can. So either by Twitter or by email to Rob or myself, we're happy to do it. And all our prior episodes are present on this QR scan. Any final comments, Rob?
I posted the link to PubMed for the paper that Ari and I wrote. Again, that's the apnea time interval for auto mode is unlike any other mode that we're aware of, and it can produce some unexpected results. So I recommend that anybody who wants to use auto mode be at least a little bit familiar with how the apnea time thing works.
Thank you very much. Well, with that, I hope everybody has a happy new year and great to start 2024 with this great set of images. Have a great day.